Approach to back pain, a systematic diagnostic framework for medical students from the Diagnostic Approach series. This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. Back pain is one of the most common reasons patients present to primary care, and it is the #1 cause of disability worldwide. Up to 84% of adults will experience low back pain at some point in their lives, costing billions of dollars annually in healthcare and lost productivity. Here is the critical insight for your clinical reasoning. While the vast majority of back pain, roughly 85%, is mechanical and self-limited, your job as a clinician is to identify the dangerous minority. Specifically, you need to rule out Cauda Equina syndrome, spinal infection, malignancy, and unstable fractures. A systematic approach allows you to efficiently triage these patients while avoiding unnecessary imaging that can lead to incidental findings and downstream interventions that may not improve outcomes. Let us start with the history, which is the most important tool in your back pain evaluation. Begin with OPQRST. Onset: was it sudden after trauma or insidious over weeks? Provocation and palliation: does the pain worsen with flexion suggesting discogenic origin or with extension suggesting facet joint or stenosis? Quality: is it a deep aching mechanical pain or sharp and shooting in a dermatomal pattern suggesting radiculopathy? Region and radiation: does it stay axial in the low back or radiate into the legs following a specific dermatome? Severity: how much does it affect daily function? And timing: is there prominent morning stiffness lasting more than 30 minutes? That is a hallmark of inflammatory back pain seen in ankylosing spondylitis and other spondyloarthropathies. The key distinction you need to make is between mechanical pain, which worsens with activity and improves with rest, inflammatory pain, which improves with exercise and worsens with inactivity, radicular pain, which follows a dermatomal distribution and worsens with Valsalva maneuvers, and referred pain from abdominal, pelvic, or retroperitoneal sources. Most critically, screen for red flags. Saddle anesthesia and bowel or bladder dysfunction suggest Cauda Equina syndrome. Fever, night sweats, intravenous drug use, or immunosuppression raise concern for spinal infection. A history of cancer, unexplained weight loss, or pain that is worse at night and unrelieved by rest suggest malignancy. Age younger than 18 or older than 50 with new onset pain, trauma in the setting of osteoporosis, or rapidly progressive neurologic deficits all require urgent evaluation. Now let us move to the physical examination. The focus back exam should include inspection, palpation, range of motion, and a thorough neurologic assessment. For detecting radiculopathy, the straight leg raise test is your workhorse. With the patient supine, passively flex the hip with the knee extended. Reproduction of radicular pain between 30 and 70 degrees is a positive test, with sensitivity around 80% for L5 and S1 nerve root impingement. The cross straight leg raise, where you raise the unaffected leg and it reproduces pain on the affected side, has lower sensitivity but specificity greater than 85%. For upper lumbar radiculopathy at L2 through L4, use the femoral stretch test. With the patient prone, extend the hip while the knee is flexed to reproduce anterior thigh pain. The neurologic exam should be organized by nerve root level. For L4, test knee extension strength and the patellar reflex, and check for medial leg sensory loss. For L5, test foot dorsiflexion and great toe extension. A patient who cannot heel walk likely has an L5 radiculopathy, and there is no reliable reflex for this level. For S1, test plantar flexion strength and the Achilles reflex. A patient who cannot toe walk likely has S1 involvement. Always check for signs of Cauda Equina syndrome, saddle anesthesia in the perianal area, and decreased rectal tone on rectal exam. If these are present, this is a surgical emergency requiring urgent MRI. If you're finding this helpful, please like, subscribe, and hit the bell icon so you don't miss future videos. For initial diagnostic testing, the most important principle is that routine imaging is not indicated for acute nonspecific low back pain without red flags. This is a key guideline recommendation from the American College of Physicians. When testing is indicated, laboratory studies include CBC, ESR, and CRP to screen for infection or malignancy, urinalysis to rule out referred pain from renal pathology, and blood cultures if spinal infection is suspected. Consider HLA-B27 testing in young patients with features of inflammatory back pain. For imaging, plain radiographs are useful for evaluating alignment, fractures, and spondylolisthesis. MRI is the gold standard for soft tissue evaluation, including disc herniation, spinal cord compression, infection, and malignancy. CT provides better spatial resolution for bony pathology and is used when MRI is contraindicated. Electrodiagnostic studies with EMG and nerve conduction studies are helpful when the clinical picture is unclear, symptoms and imaging are discordant, or there is concern for multiple levels of involvement. Remember that asymptomatic disc abnormalities are extremely common on MRI. Studies show disc bulges in more than 50% of adults over 40. Treatment decisions should never be based on imaging findings alone. The key to synthesizing your findings is pattern recognition. The most common pattern, accounting for about 85% of cases, is nonspecific mechanical low back pain. These patients have axial pain without red flags, a normal neurologic exam, and pain that worsens with activity and improves with rest. Most will improve within 4 to 6 weeks with conservative management, including NSAIDs as first-line analgesics, activity as tolerated, and avoidance of prolonged bed rest. Radiculopathy is the next most common pattern. The patient will have pain radiating in a dermatomal distribution, a positive straight leg raise, and motor or sensory deficits corresponding to a specific nerve root. The most commonly affected root is L5, presenting with foot dorsiflexion weakness, followed by S1 with plantar flexion weakness. MRI is indicated if the patient is a surgical candidate or has progressive deficits. Spinal stenosis typically presents in elderly patients with neurogenic claudication, which is leg pain with walking or standing that improves with sitting or bending forward. The classic shopping cart sign refers to patients who lean forward on a cart for relief. Finally, Cauda Equina syndrome is the emergency diagnosis you cannot miss. Saddle anesthesia, urinary retention, decreased rectal tone, and bilateral leg weakness require emergency MRI and surgical decompression, ideally within 48 hours. Now let us walk through the diagnostic algorithm. Your initial assessment should determine whether red flags are present. If yes, proceed to urgent imaging and specialist referral. If no red flags exist, ask whether there are neurologic deficits. If neurologic deficits are present, consider MRI, particularly if the patient is a surgical candidate or symptoms are progressive. If there are no neurologic deficits, manage conservatively. For timing of imaging, obtain it immediately for suspected Cauda Equina syndrome, cord compression, or spinal infection. Within 2 weeks for suspected malignancy or fracture in an osteoporotic patient. And after 4 to 6 weeks for patients with persistent symptoms despite conservative therapy who have no red flags. This stepwise approach ensures you do not miss dangerous pathology while avoiding the trap of unnecessary early imaging. There are several common pitfalls you should be aware of. First, imaging too early. Obtaining MRI in the first 6 weeks without red flags increases the discovery of incidental findings and can lead to unnecessary interventions. Second, missing Cauda Equina syndrome by not asking about bladder function and not checking rectal tone when any neurologic symptoms are present. Third, confusing neurogenic claudication with vascular claudication. Remember that neurogenic claudication improves with flexion and sitting, while vascular claudication improves with any form of rest regardless of position. Fourth, over-relying on imaging findings, since asymptomatic disc abnormalities are present in more than 50% of adults over 40. Fifth, forgetting non-spinal causes of back pain such as aortic aneurysm, pancreatitis, pyelonephritis, and endometriosis. And sixth, prescribing opioids early when NSAIDs and muscle relaxants are the appropriate first-line pharmacologic agents for acute nonspecific low back pain. Let us review the high-yield facts for your exams. Red flags to remember include Cauda Equina symptoms, cancer history with weight loss, fever with IV drug use, extremes of age, progressive neurodeficits, and pain at rest. Key exam maneuvers are the straight leg raise with 80% sensitivity for L5 and S1, cross straight leg raise with greater than 85% specificity, femoral stretch for L2 through L4, Schober test for ankylosing spondylitis, and rectal tone for Cauda equina. Radiculopathy patterns to know are L4 for knee extension and patellar reflex, L5 for dorsiflexion and heel walk, and S1 for plantar flexion, toe walk, and Achilles reflex. Remember that herniated discs compress the nerve root below the disc level. Inflammatory back pain features onset before age 40, morning stiffness greater than 30 minutes, improvement with exercise, and greater than 50% relief with NSAIDs. Spinal stenosis presents with neurogenic claudication and the shopping cart sign in elderly patients. First-line treatment for nonspecific back pain is NSAIDs, activity is tolerated, and avoiding bed rest. Thanks for watching. Don't forget to like and subscribe for more medical education videos. References for this video include Harrison's Principles of Internal Medicine, 22nd edition, chapters on low back pain and spondyloarthritis, as well as guidelines from the American College of Physicians and recent reviews published in The Lancet and JAMA. Full citations are shown on screen.